Now, it is my pleasure to follow up Dr. Missouri's inspiring talk with introducing our next panel. We have Dr. Gigi Bayoumi, who is, I know firsthand, an incredible primary care physician. She is the founder of the Rodham Institute, and she is affiliated with the Georgetown Medical Center. We have Dr. Deborah Richter, who is known throughout the state as one of the leaders in terms of single-payer health care. And we have Dr. Stephen Higgins, who's the chair of the Vermont Center for Behavioral and Health. Please come to the stage. Please welcome our panel. Thank you.
Okay. Good morning, everyone. Good morning. Good. Can we do that again? Good morning, everyone. Good morning. Great. Is it possible to get the lights a little bit? Because I don't want anybody to fall asleep. Hopefully nobody will. Good morning. I'm Gigi Bayoumi. I'm a general internist, and I'm going to be Medicare eligible in a couple of months, and I am so excited about that. I not only see patients, and my patients range from 16 to 106. 106-year-old died, and every time she would come in, she goes, "When am I going to die already?" Most centurions are not like that, actually. They're very optimistic. But also I take care of political elite, some of them are here, but from all parts of the spectrum, even a couple of war criminals in the past and present. But also I take care of people with fee-for-service insurance, Medicaid, and Medicare, homeless patients as well. I'm also an educator, medical educator, so I train medical students, residents, and fellows. I'm from Michigan. I was born in Florida, raised in Michigan, and I'm of Egyptian heritage. And when I came to Washington, D.C. almost 40 years ago, I chose to come to D.C. because it was Chocolate City. 86% of the people who live there are African Americans. That number has reduced to 46%. I don't know how much you know about Washington, D.C., but it's really important that you read about the history of it. It was actually one of the places that was on the Underground Railroad stops, and it actually was very progressive. Actually, the port, part of Alexandria, used to be part of Washington, D.C., and what happened is that the white landowners didn't like that, so they took Northern Virginia. All right, that's just sort of as background. Well, I mean, this is true. We don't have control of our own budget. Again, we don't have control of our own budget. We don't have representation in Congress. We have, shadow senators. And so all of our budget has to be approved by Congress. Now, I think that's going to change when it becomes white majority. No, truly. So I want to give you a couple of quotes because I think that this is important. Being of Egyptian heritage, there is nothing new under the sun. We keep discovering or rediscovering models. And so when we're talking about these issues, we have to look at solutions overseas and before our time. I'm going to tell you about one person, a woman from Rwanda. She decided that there should be no more plastic bags. And guess what? Rwanda no longer has plastic bags. One person. So really making sure that we study current and previous examples, I think, is key. Second thing is, how many people, this is going to be age-related, how many people know Curtis Mayfield? Okay, good. One of his songs is, "If there's a hell below, we're all going to go." So that brings me to sort of the second principle. We are all in it together. I mean, we heard a very eloquent presentation yesterday about climate change, and I think that's the theme. So let me tell you about Washington, D.C., and why I decided to establish the Rodham Institute 10 years ago. The Rodham Institute, by the way, is something I founded. I named it for my patient, Dorothy Rodham. Please read about her story, because she epitomizes how somebody who has really a horrific childhood, how education really helped her. So please read about her. So the Rodham Institute is dedicated to improving health equity through education and community partnerships. We have 181 community partners. When we first started out, listening sessions, all over the city to find, not all over the city, in wards 7 and 8, primarily, poorest wards. So DC is shaped like a diamond, right? There is the Potomac on this side, and then here is the Anacostia River. So Anacostia is predominantly African American, although that's changing as well. There's Ward 7, which is a ward that a lot of retirees, government retirees, homeowners, that's again changing, and Ward 8, which is the poorest of the poor. Here's some statistics. If you live in Georgetown, on average, you can expect to live 94 years. If you live in Anacostia, it's 66 and a half. That is the largest disparity in the United States of America over a 10-mile span. Average for urban areas is 15, 16, 17. But averages don't tell the whole story. If you live in Ward 8, you live in the highest per capita part of the country, where there's HIV, end-stage kidney disease, and cancer deaths. And if you live in Ward 8, you are living in a place where it's the same HIV rate as Namibia, where the infant mortality rate is the same as Cambodia and El Salvador. There is this inflated sense of ourselves as Americans. We're number one. Well, in healthcare, we were number 37 before COVID, and we're now number 43. Yay, we're 43, And of course, in terms of expenditures, we know the story. I don't need to go into that. So what if a woman is pregnant in Ward 8? Well, she is going to live in one of the most polluted places, and actually, environmental health or lack of environmental health is a real issue. Ward 8 is where dumping occurs, and there's no kind of monitoring, sadly, by the city. And we have an African-American mayor, right? Second, she would have to take 3 buses to get to the side of town where I live, where she can get prenatal care. And then I want to talk about something which I think is so important. Yes, access is an issue. Yes, the social determinants of health, which really determine 80% of our life expectancy, such as education, such as economic health of where we live, the water that we drink, the food that we eat, all of that. But there is something that's always missing in those discussions, and that is the dignity of the human being we're in front of. We're doing a study right now with our friends at Pennsylvania Avenue Baptist Church. We're co-creating a curriculum to see how we can increase the rates of colon cancer screening. So the first thing that we did was we did a focus group, and these are learners from the medical side, meaning medical students, not nurses or other residents and fellows, and the health ministry. The first part was we all did a survey, and then one of the women said, I would have answered this survey differently if it was for me versus my brother. Okay, my brother died a year ago from colon cancer, and on the next to the last day of his death, the physician walks in and she says, you're going to die. How would you like to die? Another patient or a person from the health ministry who's, I think, in her late 70s, early 80s, she's got diabetes. She went to podiatrist. Physicians and other specialties can be equally as obnoxious. She was sitting there. She had her, her socks and shoes off, waiting to be seen. The podiatrist looks in and says, "Soak your feet." She shared with us what she was thinking. Was I unclean? Did I do anything? And mind you, this is a lady with diabetes. It took her 3 years to make an appointment with a different podiatrist. So let's start when we're having, and this, I'm talking, preaching to the choir, respecting the dignity and the humanity of individuals that we're dealing with. And we have to be consistent in whatever venue that we are in, whether it's people that are supporting this wonderful conference, the staff that we work with, the patients that we see, whatever. Now, let's talk about good things, because I think one of the untold stories, especially from the academic side, is that there are lots of successes. First of all, there's a lot of activity in leadership, and the leadership is quite diverse in Wards 7 and 8. Lots of women leading this. And I would say that women's health impacts everybody's health. I'll tell you, in a heterosexual marriage, when men get married, guess what happens to their health? When women get married, guess what happens to their health? No, this is true. This is research-based. So let me tell you in finishing, because I told Dr. Richter that I have the gift of gab, and she had to signal me when I have 5 minutes. And we can talk a little bit more during the panel about these. But the solutions are amazing, and one of the groups that is underrepresented, but not underrepresented in community work, are other clinicians, nurses, doulas, midwives. Guess what? When a woman is pregnant and is getting her care, midwives have better outcomes than physicians, okay? One of my nieces is pregnant. She's seeing a midwife, and I really encouraged her and supported her decision with physician backup. So lots of doulas, lots of nurse-led initiatives. One of the nursing-led initiatives is from my friend, Dr. Erin Athey, who's a nurse practitioner. She talked with DC Housing and got them to basically donate 4 two-bedroom apartments in 4 different housing developments, and she's transformed them into clinics so that care can be given. Another women-led initiative is, of course, food. And again, we'll talk more about that. Women's health is everybody's health. And I want to just finish up by talking about Black women. Because whenever you do an intervention for Black women, guess what? White women's health improves. So some of the statistics that we heard, I'm going to just finish up by saying endometriosis is more common among Black women. And guess what? They're always told that they have pelvic inflammatory disease. Multiple sclerosis, number 1 in Black women. Lupus, again, disproportionate. So I'm going to just finish up by acknowledging 3 people. Dr. Vivian Pinn, who established the Office of Research, and then Dr. Bernadette Healy, who established the Women's Health Initiative. Everything old is new again. They're just versions 1.0, 2.0, et cetera. And then finally, Dr. Crystal Dixon, who is, I can't remember if she's now at Wake Forest, who did a study looking at how to improve the care and screening of women in cervical cancer and mammography. Not only did that improve the outcomes for Black women, but also for all women. So there are minorities within minorities, and if we focus on that, everybody's health improves. I'm so looking forward to having a discussion and from hearing from the rest of my illustrious colleagues here. So I'm going to turn things over to Dr. Richter. Thank you for your attention. That's Dr. Higgins.
Okay, great. So I advance the slides with this? Okay. So I'm from the University of Vermont, and I'm going to be talking about women's health and trying to advance it by addressing rural disparities in cigarette smoking. So first thing I want to point out is even though we have to attend to the crisis with opiate epidemic and other serious drug use problems, cigarettes are still killing almost 500,000 Americans every year. So it's a serious problem, and it's a problem that has really become more serious in our rural populations. So I was very excited by Dr. Missouri's, what she shared about the Women's Health Initiative. I've been working in women's health for at least the last 20 years, and I bring two examples of studies on the rural disparities. And first, I just want to show you the epidemiology, what it looks like, and I'm focusing on women of reproductive age. Why? Because of the risk for multi-generational adverse effects. So I'm going to quickly go advance my slides if I can figure out how to do it. Let's see. To this study on using the National Survey on Drug Use and Health, which is a nationally representative survey of U.S. citizens, and it's looking at people aged 12 years and above. And what we're going to do is first look at smoking, current smoking status. That just means that you've smoked in the past 30 days and you've smoked at least 100 cigarettes in your lifetime. And then we're also going to look at, and we're going to compare rural women of reproductive age against urban women of reproductive age. And then we're going to look at things, something called quit ratios, which is simply how many, it's former smokers. You met criteria for lifetime smoking, but you haven't smoked in the past year. And so the data, and then we're going to adjust for race, ethnicity, education, and income to show that the rural disparity is not just about those, but it's what we think is a lack of access to evidence-based treatment, smoking cessation, enforcement of tobacco regulations, that sort of thing that is contributing to this disparity. Okay, so the rust color are the rural women, and the blue are the urban women, separated, not pregnant and pregnant, and you can see very clearly prevalence is way higher in the rural than the urban women, and this is 18 continuous years just because we wanted to look at time trends using common methods, and that was the period we could look at. And if you just look at the non-pregnant, what you see is not only are the urban women less likely to be smoking, but the trend is steeper, the decline is steeper, so the disparity is growing. And then when you look at the pregnant women, there's more variability just because the numbers are smaller. Only about 4% of U.S. women are pregnant at any one time. But you see the same pattern. So we have a problem. And what I want to do, I'll quickly show you the same thing for former smokers. Now it flips. More former smokers urban than rural. Okay, so what can we do about it? I'm going to just show you one study that we have conducted recently, taken on perinatal women, pregnant women in particular. Well, I mean, I'm particularly interested in the pregnant part of the perinatal status. So I think many of you already know this, but smoking is the leading preventable cause of poor pregnancy outcomes. And I already showed you the disadvantage. And we have treatments that are available for them, smoking cessation treatments, but the quit rates are awful. About 10% of the women will quit when they get one of these treatments. It's usually a referral to a quit line. So think about what kind of treatment should we be happy about when 1 in 10 benefit from the treatment? So what we've experimented with for the last 20 years is, can you incentivize behavior change in the pregnant women? And the answer is you can, but I'll show you it from a recent study we did. And I want to just try to move fast so we have a chance for a Q&A. But the incentive model we're using are vouchers exchangeable for retail items, and we offer them to the women from around late first trimester through 12 weeks postpartum. These vouchers are provided contingent on biochemical test results, and so we're not just giving them away willy-nilly. They have to show us they haven't smoked recently, and these vouchers are available for about 9 months. If someone abstained throughout, they could earn about $1,100, but the results I'm going to show we get for only $500 on average. That's a pittance in healthcare costs today, but the results are quite impressive, I think. So the blue bars, this is in the top panel there. Just to keep things simple, the blue bars are the people who are incentivized. The red bars are the usual, or we're calling it best practices, but without incentives. So just by adding the incentives onto the best practices, you get up to about 40% of the women to quit during the pregnancy, and that effect tapers some after delivery, but remains above if you've got incentives, meaning the women are en route to lifetime quitting. And in the bottom panel, all I'm showing you is that it's a very reliable effect. We've done 5 trials, and they're summarized in the bottom panel. All right, so this is I'm especially encouraged by this finding. This is the percent of women who have small for gestational age deliveries, so they're called SGA deliveries, and SGA does 2 things at least. It increases the risk for SIDS, sudden infant death, in the first year, and it also puts the child on a path for metabolic disorder later in life. So really serious adverse outcomes. The upper and lower panels, the red is you didn't get incentivized, the blue is you did. You can cut SGA in half. So important outcome. You can do something about it. You incentivize outcomes, and not with large incentives. Okay, so to wrap up, there's robust empirical evidence that financial incentives are efficacious, cost-effective. We did cost-effective analyses, $4 to $12 recovered for every $1 invested in this incentive intervention. The United Kingdom can move faster. I'm looking at Senator Sanders. I'm sure he understands why they can move faster with this kind of thing. They already announced they're going nationwide with this intervention. We're making progress. I'm meeting next week with Vermont officials. We're inching our way along, but we're getting there. Financial incentives are efficacious for other substance use disorders, including stimulant use disorder. California has a statewide implementation study underway. Vermont and other states are moving forward. There's a sound scientific rationale for why financial incentives work. They stimulate the same brain reward centers that abuse drugs stimulate to cause addiction. And then they also accommodate the tendency for people with substance use disorders to need immediate rewards versus delayed rewards. So this kind of provides some healthy immediate rewards for healthy choices. Lastly, I want to end on a positive note. I'm very excited about this treatment moving forward, including here in Vermont. The incentive-based treatment, we're using it, we're moving forward with the pregnant women, but we're also moving with illicit drugs here in Vermont. But if we're going to do better with reducing health disparities for substance use disorders, we have to learn to move evidence-based treatments into community use faster. So the first study on psychomotor stimulants and incentives we published in 1991. And on the smoking during pregnancy, 2004. So it's 20 and 30 years to get these out into the community. Better late than never, but I think we can do better. Thank you.
slides. How do I advance?
And hopefully zero in on a specific thing that we can do, at least here in Vermont, to start the ball rolling again with healthcare reform. Decades ago, Walter Cronkite once said that the U.S. healthcare system is neither healthy nor caring nor a system. And decades later, it's still true. But I think that's the bad news. The good news is that it is possible to cover every single Vermonter, every single American with comprehensive coverage without spending a penny more than we're spending currently. That we know, we've known for a long time. We've had many, many studies. Now, don't panic. I just have a few slides. Okay, I know how that must look. But anyway, we're spending, as Bernie said last night, twice what other countries are spending on average in terms of percentage of GDP and in per capita. And again, a lot of this is unnecessary spending, and I'll talk briefly about that. But in addition, I think it's important for us to understand that we pay the highest healthcare taxes in the industrialized world. If you see that area in yellow, that's what we spend in taxes to pay for this dysfunctional healthcare system. In addition, the private spending, so that's health insurance and out-of-pocket spending, for a total of $13,420 per person. We could buy any of these other healthcare systems. That's what their spending is in total. And they cover everyone, and they do better. Our life expectancy is dismal compared to these other industrialized countries that cover everyone for half the cost per person. Infant mortality is disgraceful. And again, poor women do far worse, and poor infants. And U.S. mothers, again, poor mothers do much worse. So we really have nothing to brag about. So we're spending twice as much. Our outcomes aren't as good. And let's keep in mind that the spending crowds out all the other things that we're talking about. Housing, social programs, drug rehab programs, education. Those things can be addressed if we were spending less money over time on health care. So if we're not spending it on, where are we, who are we spending the money on? It's certainly not on health insurance for everyone, right? So this is basically a study done in 2022 that showed 40% of insured Vermonters were underinsured, meaning a major illness would cause financial bankruptcy. I take care of patients. I'm an addiction medicine specialist now, and I take care of patients with opioid addiction, alcoholism, cocaine addiction. And what this means now is being underinsured, patients are losing their Medicaid. So what does that mean if you're in treatment? Because if you're in treatment for your addiction, you're less likely to overdose and die. So what happens? You're on Medicaid, you lose your Medicaid, and you have a choice of either buying the coverage, which doesn't cover anything, or paying for housing or paying for food, and ending up like a few of my patients in a tent. One of my patients is, his girlfriend is about to give birth, and they no longer have housing. So in a few weeks, she may end up in a tent, he and she and the baby. I don't know yet. Maybe they'll be able to get a last-minute hotel. But what kind of an upbringing is that? And kids are basically shepherded from one hotel to another. I see this all the time. Now try to remain sober in a tent city. When people are using drugs around you, try to remain sober. These are things that we are crowding out by paying unnecessary, sorry about that. So if we're not spending it on people, what are we spending it on? Well, it turns out we are spending an enormous amount of money on administration. So this is Duke University Hospital Medical Center, 957 beds with 1,600 billing clerks. And a hospital, major hospital, a bigger hospital in Canada with 1,200 beds, 7 billing clerks. That's actually for just Americans who wander across the border. Otherwise, basically, they're globally budgeted. They know what their revenue is every month. So this is where we're spending a lot of our money. So 31 to 35% of the healthcare dollar goes for this. It turns out healthcare is a great jobs program for administrators and billing clerks. And in fact, managers, which we've seen since 1970, comparing the number of managers and healthcare administrators, we've seen more than a 4,000% increase since 1970. More than 4,000% increase. And yet at the same time, that little yellow is the amount increase in the number of doctors. So these are folks that do not administer healthcare. They don't take your blood pressure. They don't prescribe your medication. They don't take care of your diabetes. They just sort of manage and drive us absolutely crazy. And again, you want to know why nobody's going into primary care? Managers. So what should we do? Well, it turns out that in 2011, Vermont passed single payer, essentially Act 48, which basically the bill was supposed to provide comprehensive coverage, publicly funded coverage to all Vermonters. It was never implemented, but it is still the law. So what should we do? Well, we have been trying since, the governor and the legislature dropped the whole ball in 2014, and we've been trying since 2015 to get a universal primary care bill passed. We made it a few times. We did get a study done. But why primary care? Well, it turns out if everyone has access to a primary care clinician, it is the only sector that has been shown to improve population health, lowers infant mortality. We know this. This is not disputed, all of these benefits. Not only that, it's cheap. It turns out, we did the study. It was less than 6% of total. And that included mental health services, outpatient mental health services, and outpatient substance use disorder services. All included, because that's our definition of primary care in Vermont, including those other services. We could do this, sounds like a lot, for $200 million. Again, we're already spending, that would be a net increase of $60 million per year. Now, this is a small price to pay, a huge return on investment, and it is something that we could do at the state level. We had a bill that sat on the wall this year, 59 co-sponsors in the House, and 10 co-sponsors in the Senate, so it's H-156 and S-74. We intend to push for it again. This is, again, a relatively small ask when you consider that Vermont is going to spend $6.8 billion on health care. And so to add a net $60 million in terms of taxes. We're replacing, however, no more premium. You do not need a universal primary care. What does that mean? It means that every Vermonter would not need private health insurance for primary care, mental health, and substance use disorder services. That would be removed from the health insurance. And we would publicly fund it and extend it to everyone. And then over time, the next year, we're adding preventive dental and eye care. The year after that, we can keep adding sectors of care. Now, that was because the legislature had no appetite for the whole thing at once. That's why I'd rather it all be done at once. But it is a heavy lift. But this is possible. So we have a Universal Healthcare Caucus that we've started. Again, Representative Brian Chena, I believe he's here. Yes, okay. And if anyone, we're asking all Vermonters, we have doctors, we have nurses, we have representatives. As part of this caucus, we've met 3 times. And you can meet by Zoom or whatever, join us, and help us push forward universal primary care. Thank you. Do we have time for questions?
I don't know, what is our time?
Yeah, do we have time for questions, or should we just, what's?
Wrap up with your discussion.
Okay. All right. Okay.
I do. There's a lot that I could have spoken about, but I want to say a couple of things. First of all, it's important to do women's health research, just like minority health research, because there are things that are different. One of them is alcohol use. Women should not drink more than 7 drinks in a week. It doesn't matter if it's beer, wine, or hard liquor, because cancer rates go up. Men, 14. Since COVID, there have been drinking parties among women. The number of liver transplants has gone up. I actually just had a patient die of liver failure. Let me talk about an excellent model. You know, yesterday there was discussion that we can do this. Well, we did it during COVID. World crisis, everybody came together from science and advocacy groups and communities. I mean, it's pretty remarkable that within, a year, give or take, you had a vaccine that was available. I mean, we were lucky that the virus is extremely simple. So let me tell you about the Black Coalition Against COVID, of which I'm a founding member. So among African American patients, the numbers were low. So what was the model that we used to improve those numbers? We had the 4 historically Black medical schools, we had nurses, we had people from the hip-hop community, the go-go community, the fraternity, sororities, the garbage workers. We had everybody at the table. The model that we used, we did a 1-day mass vaccination event in Ward 8, 900 people were vaccinated. What was the model that we used? Did a train the trainers model. I did 9 19-minute sessions with one of the large community-based groups that does services. What did that do? It increased the educational, social, capital of that group, so that if Rodham disappeared tomorrow, they still have that knowledge. They were the ones that were educating. So I can't stress enough, community needs to be at the table. The people that are closest to the problem know the solutions. We leverage science and our different fields of expertise to make things happen. But if we're going to make a difference in health disparities and women's health, women are the caretakers for the family. Women have the greatest burdens in terms of navigating everything, because our corpus callosum, which connects the 2 parts of the brain, is this big. So there's, that so much stuff that we're handling. So women's health is family health, is children's health.
Yes. Well, I think I summarized with my talk, but basically I just want to give people hope. I think this entire audience is reason for inspiration. All the conversations this morning, people truly care, and I do think the majority of American people care. We need to get more people involved and give people hope that we can strive to help each other and live, again, a better life, and people deserve that.
I'll end on my last point in my presentation about prioritizing the movement of evidence-based treatments for substance use disorders into community clinics. And with the opioid crisis, we did a reasonably good job on medications, but medications alone are not adequate. And with behavioral interventions, the incentives are an example. It has been too slow, and these delays cost people's lives. So I would leave it there. We just have to do better in getting the community clinics equipped with evidence-based treatment.
So what Fauci said, which is so important, science implementation is key. I would urge everybody to read, if you don't already know, about what he did during the AIDS epidemic in terms of engaging the people that were most affected. And I would say, if you want to improve people's life expectancy by 10 years, make sure they graduate from high school.
Yeah. Okay. Very good.
We're just going to take a shorter break this time. The next panel is going to be in this room in 5 minutes, so you can stand up and stretch, talk among yourselves, but then please come back for the next panel. It should be incredibly interesting. Thank you so much. You've given us so much to think about: research, science, and incentives, behavioral health. Thank you.